Hi, my name is Megan Chambers. I'm a resident at the University of Washington, and in this video, we'll be looking at the gross features of the GI tract. There's a lot of ground to cover, about 5 feet of colon, stomach, esophagus, also liver, pancreas, so on. But we're going to focus on two main systems, the bowel and the liver. As with other videos in this series, specimens are part of the University of Washington Autopsy teaching collection, and therefore are formalin fixed rather than fresh tissue. This can mean that they're slightly darker and firmer than tissues you might otherwise see. To get started, we'll be looking at specimens from the bowel. We'll start with common benign entities, moving through infectious entities, finally finishing with more aggressive malignant entities. We can start by appreciating the normal parts of this portion of large bowel and colon. It has easy to identify pouches called haustra, alternating with the circumferential constrictions called the semilunar folds. There's a uniform thickness to the bowel wall and a uniform color to the mucosa, which unfixed would be pink, but fixed looks more tan. This bowel is relatively healthy and is a good baseline for normal. It does have some pathology though. These little narrow openings leading to deep pouches, these are diverticula. We can even see the impacted stool that can get stuck in them called fecaliths. The fecaliths are what cause obstruction and then infection and diverticulitis. Diverticula frequently occur in one or more parallel rows down the colon. That's because they tend to occur along the entry points where the vasa recta penetrate. True diverticula, as in this case, include all the layers of the bowel, while false or pseudodiverticula involve only the mucosa or submucosa. They're most commonly located in the left colon, where primary risk factors are increasing age, as well as lifestyle factors including decreased fiber intake and decreased activity. Over half of people 60 years and older have diverticula. The next specimen is melanosis coli. The top half of this loop of bowel is colon. It's not as clear as in the last specimen, but there are folds and pouches. And then the bottom half of the loop is a smaller caliber section of bowel with a smoother surface. This is the small bowel. So the specimen as a whole is small bowel and colon at the ileocecal junction. And the colon part has a much darker chocolatey brown color to the mucosa compared to the small bowel portion, which matches the tan that we saw in the last specimen. The dark brown pigmentation is the melanosis coli, which is classically seen abruptly starting in the large colon. It can be worse in the proximal large bowel compared to the distal, and it's caused by pigment deposition from anthraquinone laxatives, such as senna, rhubarb, and aloe. The pigment is not from the laxatives, but rather from lipofuscin. The laxatives induce apoptosis in mucosal epithelium, which is phagocytosed by macrophages, leading to the accumulation of the degradation byproducts, including lipofuscin. It's thought that the laxative requires activation by colon bacteria, which is why there's less pigmentation proximally in the small bowel. Because the underlying mechanism is apoptosis, other conditions with increased apoptosis can also cause melanosis coli, including colon cancer and inflammatory bowel disease. The next couple of specimens represent pseudomembranous colitis, commonly caused by C. diff infection. The specimen appears to contain diffuse polyp-like excrescences, but upon closer inspection, they don't have either the pedunculated bases or the sessile finger-like tips of typical polyps, which we'll see in a minute. They're actually plaques, which prior to fixation usually look yellow-white. They coalesce to make a pseudomembrane. On histology, these excrescences are composed of inflammatory debris, rather than hyperplastic tissue. These specimens are not commonly seen in routine surgical cases thanks to successful antibiotic treatment protocols. However, untreated C. diff can present with spontaneous bowel perforation or other life-threatening complications requiring surgery. This is a picture from such a case, and we can see the pink mucosa contrasting with the white pseudomembranes. This is another example of pseudomembranous colitis, which looks somewhat flatter and more diffuse. If we were to compare this to our very first specimen, where the mucosa was smooth and homogeneous, this is more rough and bumpy. We can even see a gradient in the membranes as we go along the length of the colon, from more severe on the left to less severe on the right. This next specimen is a large portion of a patient's entire bowel, including small bowel and colon. This is an example of toxic megacolon, which I previously mentioned as a complication of C. diff infection, but can be seen in essentially any inflammatory condition. Most classically, it's associated with ulcerative colitis. It's diagnosed based on a luminal diameter of 6 centimeters or more, usually diagnosed on radiography, although we would use the same criteria to confirm the diagnosis on gross examination. We can see that in this specimen, portions of this colon greatly exceed that cutoff. The main differential here would be acquired megacolon, which is dilation due to chronic constipation or diffuse gastrointestinal dysmotility. As we move into neoplastic conditions, these two specimens give us an abrupt introduction into polyps of the GI tract. These specimens both come from patients with familial adenomatous polyposis. The diffuse back-to-back growth of pedunculated polyps is immediately apparent. These polyps commonly occur throughout the length of the GI tract, but they're more common in the colon and duodenum compared to the ileum and jejunum. They're also present in the stomach. There are essentially two morphologies for polyps, at least grossly: sessile and pedunculated. These polyps are examples of pedunculated polyps with a stalk and nodule at the terminus. In this section of bowel, we have some large caliber colon on the left, smaller caliber ileum on the right, and even an appendix protruding from behind the specimen. This means that we're in the ileocecal junction. In the colonic portion of the specimen, there's this single large polyp. This is a sessile polyp, which means that it has a broad-based attachment to the mucosa. Sessile polyps are more common in the right colon, as we have here. The main thing to note is that as I move it, the polyp is relatively mobile and slides, suggesting the mucosa is not adherent to deeper levels of the bowel. Although we would have to confirm it histologically, this is most compatible with a non-invasive polyp or adenoma. This next specimen contains rectum on the right, a large polyp-like mass in the middle, and normal colon on the left. The next polyp looks very similar to our last one, with these broad-based fronds extending from the mucosa. But as we can see in the cross-section here, it's more adherent to the underlying submucosal layers of the bowel. This is in keeping with an invasive carcinoma. This is also a rectal specimen, although the rectum is on the left here rather than the right. There's a large central mass just proximal to the rectum. In contrast to the last two specimens, where there was a clear polyp precursor, this specimen shows the dense infiltrative nature of the carcinoma. It expanded both the superficial and deep layers of the bowel, making the normally thin and pliable wall into a dense mat of firm tissue. Of note, this specimen is black on the outside because it was inked, so that on histology the margins of the surgical resection could be evaluated in relation to the carcinoma. Next, we'll look at sections of liver, including benign and neoplastic processes. This first specimen is a section of normal liver. When fixed, it's commonly a tan to light brown, but when fresh, it would be red. The texture when it's fresh should be firm, but easy to press through a 1 centimeter slice with your fingers. Extra resistance can mean there's increased fibrosis, such as with cirrhosis. But if it's falling apart, then there could be a disease process, such as infection. Since this is fixed, it's already a bit firm just from the formalin. We can also get hints at the underlying architecture by noticing the regularly spaced vessels. The capsule of the liver should be smooth and uniform, as we see here. I'll keep the normal liver in the frame on the right for comparison. The specimen on the left is a hemochromatosis liver. We can immediately tell it's a drastically different color. Even after fixation, it's a deep red. It's a uniform discoloration without accentuation or areas that are uninvolved, so we can say that it's probably a diffuse and uniform process, which would be consistent with hemochromatosis. Recall that hemochromatosis is an iron storage disease, and we could also see findings such as cirrhosis in these patients. Extrahepatic manifestations also include skin hyperpigmentation, cardiomyopathy, and hypogonadism. A couple other generally diffuse processes. We can see that again with this specimen, color is one of the key differences. This is steatosis or fatty liver disease, which imparts this yellow to off-white color to the liver. Steatosis is most pronounced and most commonly seen in alcoholic and non-alcoholic fatty liver disease. Grossly, there's no way to distinguish the various causes of steatosis. Risk factors for NASH include obesity and metabolic syndrome. This next specimen is cirrhosis, which is the end-stage disease process for many liver pathologies, from NASH to infectious hepatitis, etc. It's nice because the microscopic architecture is visible grossly. That is to say that we can clearly identify innumerable small nodules of tan-brown liver parenchyma, which are connected by intranodular fibrosis around each of the nodules. This specimen combines some of the features we've been talking about. It's a steatotic liver with cirrhosis. If we compare the last three specimens back to back, we can see that the middle specimen, our current specimen, has the faint yellow coloration of the steatotic liver, which is on the left, and the nodularity of the cirrhotic liver, which is on the right. The last two specimens represent dramatic examples of neoplastic processes in the liver. The first one represents the prototypic intrinsic neoplasm, hepatocellular carcinoma. All of these large nodules throughout the parenchyma are nodules of locally disseminated hepatocellular carcinoma. You could, of course, have just one nodule or a couple nodules, but this specimen is representing a relatively advanced case. This is in contrast to a metastatic carcinoma. Metastatic disease is more common in the liver than are intrinsic malignancies. Because of the dual blood supply, it's susceptible to a wide range of cancers, as blood draining from most organs in the body eventually passes through the liver. About 25% of all metastases occur in the liver. The most common is colorectal cancer, and that happens to be what this case is from. We can't tell the origin of metastases from the gross examination, but knowing that this is colorectal cancer, we can say that this necrosis and friability we see in the nodules is not uncommon with colorectal cancer. That concludes our look at gross features of the GI tract, especially the bowel and liver. Thank you all for your time. In particular, thank you to the donors who provided these teaching materials at the University of Washington as part of their routine autopsy care.